Good morning, Srikanth.
Sir, good morning, sir.
Good morning, Raman Prasad garu.
Good morning, sir.
ఇంకో 2 నిమిషాలు ఆగి స్టార్ట్ చేద్దాం సార్.
అలాగే సార్.
Good morning, Jairam. స్టార్ట్ చేద్దాం సార్.
అలాగే సార్.
ఓకే జయరామ్ స్టార్ట్ చేద్దాం.
Good morning to all of you. Today my topic is anesthetic management of intracerebral aneurysm clipping. What is aneurysm? Aneurysm depends upon three factors. One is constitutional, absence of external elastic lamina, and next is morphological. The cerebral vessels, they unique, they bifurcate, they curve, recurve. At the point of bifurcation, there is a weakening of the tunica media. And third factor is dynamic factors, flow velocity and pressure. Bombardment of the vessel wall, especially in hypertensive patients, at the point of bifurcation, there is a ballooning out of the vessel wall. This is called aneurysm. Epidemiology estimates the incidence of cerebral hemorrhage is 10 cases per 1 lakh person per year. It is most frequently in the 5th and 6th decade. Ruptured intracranial aneurysm may account for 5 to 15% of these strokes. Approximately 75 of spontaneous episodes of subarachnoid hemorrhage are caused by ruptured cerebral aneurysms. How they are clinically present? The sudden onset of severe headache. They almost complain this is the worst headache they have experienced in their life. Sometimes there may be warning headaches weeks or months before the rupture due to sentinel bleeds. Then nausea, vomiting, and neck pain, photophobia, meningism, transient loss of consciousness, epileptic seizures, focal neurological deficits. Aneurysms are associated with some Marfan syndrome, Ehlers-Danlos syndrome, pheochromocytoma, autosomal dominant polycystic disease, AV fistulas. Most genetically, hemodynamically, nicotine abuse, alcohol abuse induce structural defect. Few may be caused by infections and trauma. 80 to 90% aneurysms are located on the anterior circulation and anterior and posterior communicating and middle cerebral artery. 10 to 20% are located on the posterior circulation, vertebrobasilar circulation. Major complications of subarachnoid hemorrhage, they rebleed. On day 1, the incidence is 15%. By 1 month, it is 40%. Cerebral vasospasm leading to immediate and delayed cerebral ischemia, hydrocephalus, seizures, cardiopulmonary dysfunction, electrolyte disturbances, hyponatremia, hypernatremia, hypokalemia, hypocalcemia, hypomagnesemia. Management, early intervention after subarachnoid hemorrhage is ideally within 24 hours or definitely within 48 to 72 hours. Intervention may entail either operative clipping or endovascular approach, coiling. Early intervention was originally undertaken only in patients of grade 1 and 3. In early intervention is not feasible. Surgery is usually delayed for 10 to 14 days to be safely beyond the period of maximal vasospasm risk, that is day 4 to 10th of post-subarachnoid hemorrhage. The aneurysms are graded small, large, and giant. Small is below 1 centimeter, large is 1 to 2.5 centimeters, giant are more than 2.5 centimeters. More common is small aneurysms. Advantages of early intervention: it is less likelihood of rebleeding, which is the principal cause of death of the patient hospitalized after subarachnoid hemorrhage. Management of ischemia caused by vasospasm involves euvolemia and induced hypertension. Vasospasm is due to the presence of blood in the basal systems in the vicinity of circle of Wills. Some of this blood can be removed at the time of aneurysm clipping, and intracisternal fibrinolysis can be administered. The blood in the basal system is appears in the CT scan as star sign. Early operative clipping makes the therapy of vasospasm safer and reduce the incidence of and severity of the problem. Early aneurysm clipping reduces the period of hospitalization, reduces the complications such as DVT, atelectasis, pneumonia. Predictors of mortality. The three main predictors of mortality are impaired level of consciousness on admission, advanced age, large volume of blood on initial CT. Initial investigation in a suspected subarachnoid hemorrhage, full blood count to rule out anemia and leukocytosis, coagulation screen rule out coagulopathy, urea and electrolytes to rule out hyponatremia, serum glucose, hyperglycemia associated with poor outcome, magnesium hypomagnesemia associated with poor outcome, chest X-ray to rule out pulmonary edema and aspiration, 12-lead ECG, ST segment changes and QT interval prolongation common in subarachnoid hemorrhage, unenhanced CT as soon as possible within 24 hours after the onset of sudden severe headache. Lumbar puncture if CT is normal in case of suspected subarachnoid hemorrhage. CT angio if a subarachnoid hemorrhage is confirmed by CT or lumbar puncture. Fisher's grading of cranial CT. Grade 1, no subarachnoid blood detected. Grade 2, diffuse or vertical layers less than 1 millimeter thickness. Grade 3, localized clot or vertical layers greater than 1 millimeter. Grade 4, intracerebral or intraventricular clot with diffuse or no subarachnoid hemorrhage. This is again modified Fisher's grade. 0, no subarachnoid blood. Grade 1, thin subarachnoid hemorrhage, ventricular blood clot. Grade 2, thin subarachnoid hemorrhage with grade 3, thick subarachnoid hemorrhage with or without intraventricular hemorrhage. Grade 4, thick
discharge anta chudama
ventricular blood clot. The three methods of choice for detecting and delineating the anatomy of intracranial aneurysms are CT angio, MRI, catheter angiography by intra-arterial catheterization. The development of three-dimensional rotational catheter angiography allows rotation of the formatted images and assessment of the aneurysm's relationship to the other vessels. Assess the neurological status and subarachnoid hemorrhage grade. Food gases are more likely to be associated with elevated ICP, impaired cerebral autoregulation, cardiac arrhythmias, myocardial dysfunction, electrolyte abnormality, hypovolemia, and poor outcome. Total clinical grades for patients with subarachnoid hemorrhage was initial grading in the year of 1956. Now this is not followed. WFNS scale for subarachnoid hemorrhage. Here Glasgow Coma scale and motor deficit. Grade 1 and 2 are good prognosis. As you go down, grade 4 and 5 are poor prognosis. Motor deficit is absent in grade 1 and 2 with grade 1 is GCS 15, grade 2 is GCS 14 to 13. In grade 3, motor deficit is present and GC says 14 to 30. In grade 4 and 5, there are poor GCS score with motor deficit present or absent. Hunt and Hess grading of neurological status of subarachnoid hemorrhage. Grade 1, here also grade 1 and 2 have good prognosis, and grade 4 and 5 poor prognosis. Grade 1 and 2 are asymptomatic with mild or severe headache. Grade 3, there may be focal neurological deficit. Grade 4, patient is in stupor and there is early decerebrated rigidity and moderate to severe hemiparesis. Grade 5, deep coma, decerebrated rigidity. So what is the importance of this grading? FNS, the World Federation of Neurological Society, Hunt and Hess grading, they prognosticate what is the outcome. In grade 1 and 2, the outcome is recovery rate is 5%, whereas in grade 5, it is 50 to 80% mortality. So, importance of grading the aneurysm to know the mortality outcome of the subarachnoid hemorrhage. The Fisher's grade helps in assessing the what patients are going for vasospasm. In grade 1 and 2, there is little chance of going to vasospasm, whereas in grade 4, there are more chances of going into vasospasm. Preoperative evaluation, CT angio, to know the site and size of the aneurysm, extent of the subarachnoid hemorrhage, hydrocephalus, vasospasm, collateral circulation. So, subarachnoid hemorrhage is a systemic disorder. You have to evaluate the other systemic functions likely to be affected by SAH: cardiovascular system, respiratory system, and serum electrolytes. ECG changes occur in 40 to 100% of the subarachnoid hemorrhage. Exclude dyselectrolytemia like hyponatremia, hypokalemia, and hypocalcemia. ST elevation, symmetrical T wave inversion, prolonged QT interval, cardiac enzyme tropi greater than 2.8 nanograms per ml. Diagnostic dilemma should not be delayed surgery. It may alter the anesthetic plan.
Sir, alter the anesthetic plan, alter the outcomes.
Sir,
It
anesthetic
alters the anesthetic plan, sir.
అంటే ఎక్స్టెన్సివ్ కార్డియాక్ ఫెయిల్యూర్ కానీ లేకపోతే మ్యాసివ్ ఎంఐ కానీ ఉంటే have to be treated first before clipping.
Thank you, sir.
Intravascular volume and serum electrolyte disturbances correlate with the clinical grade. Hypovolemia, hyponatremia. Common cause of hyponatremia is cerebral salt wasting and syndrome of inappropriate ADH. In cerebral salt wasting syndrome, it is hypovolemic hyponatremia. You have to correct the volume, or fludrocortisone should be given. Correcting the volume with isotonic saline or 3% saline. In syndrome of inappropriate ADH, it is euvolemic or hypervolemic hyponatremia. So fluid restriction should be given. Hypokalemia, hypocalcemia. Respiratory system, neurogenic pulmonary edema and aspiration pneumonia. Neurogenic pulmonary edema occurs because of the increase in the sympathetic discharge. There may be blood in the alveoli, frank pulmonary edema. Review ongoing treatment. Anticonvulsants interact with the non-depolarizing muscle relaxants. Patient may be getting nimodipine. So perioperative hypotension should be suspected. Steroids are not used nowadays. antifibrinolytic agents. Like rebleeding is less in patient with using antifibrinolytics. So a short course of tranexamic acid or epsilon aminocaproic acid within 72 hours of the bleed may prevent rebleeding. Other comorbid illness, communicate with the neurosurgeon, physician, requirement of special monitoring. Timing of surgery, early surgery within 3 days of subarachnoid hemorrhage, it is brain will be edematous and patient will be less optimized. So surgery may be technically difficult. Delayed surgery after 7 to 10 days, there is more chance of rebleeding, but the brain will be, edema will be settled by that time. Types of surgery, clipping or endovascular coiling. You should optimize the patient by correcting physiological and biochemical disturbances. The goals of anesthetic management is control of transmural pressure gradient of the aneurysm and cerebral perfusion pressure. Both are determined by the difference between the mean arterial pressure and the intracranial pressure and therefore numerically identical. Preservation of the adequate cerebral perfusion pressure and oxygen delivery. Avoidance of large and sudden swings in the intracranial pressure. Providing conditions that allow optimal surgical exposure with the least brain retraction, allowing rapid awakening of the patient. Pre-medication, sedatives are best avoided in poor graded aneurysms. They barbiturates and narcotics, they cause respiratory depression, they interfere with the neurological assessment. Angiolitis can be given in grade 1 and 2 aneurysms. Already intubated and mechanically ventilated patients, you can use sedation and muscle relaxant. Anticholinergics like diethylpyrrolate can be given. Continue nimodipine, dexamethasone, and anticonvulsants. What are your anesthetic concerns during induction? Induction should be smooth. Aneurysm rupture during laryngoscopy and intubation. Cerebral ischemia can be, induction agents can cause cerebral ischemia. So what are your anesthetic goals? Minimize transmural pressure, maintain adequate cerebral perfusion pressure. Cerebral perfusion pressure and luminal pressure is equal to MAP minus ICP. Balance benefit of the improved perfusion against risk of rebleeding. Try to maintain transmural pressure and CPP at preoperative level, 20 to 30% above or below. Good SAH grade and poor SAH grade during induction. What will you do? Good SAH near normal intracranial pressure. Poor subarachnoid hemorrhage will have raised intracranial pressure. Good subarachnoid hemorrhage, there are more chance of rupture. Poor subarachnoid have more risk of ischemia. Can tolerate fall in blood pressure up to 30 to 35%. Poor subarachnoid hemorrhage cannot tolerate much fall in blood pressure. Good SAH grade cannot tolerate much fall in cerebral blood flow, so don't hyperventilate, or near normocapnia should be maintained. Poor SAH grade, hyperventilation improves cerebral perfusion pressure. IV induction is preferred. Titrated dose of pentothal sodium or propofol. Prevent hypertensive response to laryngoscopy and intubation. Maintain adequate depth of anesthesia. You can give Xylocort, beta blockers, narcotics, top-up dose of narcotics. Muscle relaxant, pecuronium or rocuronium. Difficult airway, fiber optic bronchoscopy guided intubation, obtuned clot reflex with IV narcotics, lignocaine nebulization can be given before intubation. Intraoperative monitoring, routine monitoring like SpO2, EtCO2, NIBP, ECG, temperature monitoring, urine output, special monitoring, invasive blood pressure monitoring, ABG, electrolytes, serum osmolality, blood glucose, central venous pressure, pulmonary artery wedge pressure, jugular venous valve oxygen saturation, EEG, transcranial Doppler, evoked potential somatosensory evoked potentials, brain stem auditory evoked potential can be monitored. CVP indications: pre-existing hypovolemia, large intraoperative fluid shift with use of osmotic or loop diuretics, potential risk of aneurysm rupture requiring fluid resuscitation, institution of triple H therapy, coexisting myocardial dysfunction, avoid excessive tendon back tilt and neck rotation. Positioning of the patient, anterior circular aneurysms, frontotemporal incision, supine position. Basilar tip aneurysm, subtemporal incision, lateral or supine. Vertebral or basilar trunk aneurysm, suboccipital incision, park bench position or seated position. Take care of bony prominence, eyes and peripheral nerves. Tracheal tube position, venous drainage from head and neck, venous air embolism. Goals of anesthesia: relaxed brain or slack brain, adequate cerebral perfusion, avoidance of rapid increase in the transmural pressure, absolute immobility, prompt awakening. Anesthetic agents: oxygen, compressed air, isoflurane, short-acting opioids like fentanyl, sufentanil, vicuronium, rocuronium. TIVA, propofol plus short-acting opioid plus short or intermediate acting muscle relaxant, better control over cerebral dynamics, rapid and predictable titration, preferred in poor subarachnoid hemorrhage grade. Crucial points of increased stimulus: laryngoscopy during intubation, positioning, placement of pinhead holder, Mayfield pinhead, tripin pinhead holder, rising bone flap, retraction of cranial nerves and brain stem. Little or no stimulus once dura is opened. So at the placement of, while doing a placement of pinhead holder, you should give a top up of the narcotics and maintain the depth of anesthesia. Brain relaxation, 3 basic measures: brain tissue volume reduction by mannitol, CSF volume reduction by lumbar CSF drain, cerebral blood volume reduction by hyperventilation. Mannitol 20%, 0.5 to 2 grams per kg, triphasic action, reduces cerebrospinal fluid production, antioxidant, theoretically should not be given before dura is opened. Lumbar drainage of cerebrospinal fluid, minimize sudden cerebrospinal fluid loss during drain placement, risk of rebleeding, contraindication intracerebral hematoma, theoretically drain after opening dura 20 to 30 ml before dural opening, rate of drainage should not exceed 5 ml per minute. Why? Because rate of production of CSF is 5 ml per minute. Rapid drainage reflects hypertension. Hyperventilation, 2 to 3% of cerebral blood flow change per millimeters of PaCO2 change. Mild hypocapnia, 30 to 35 millimeters before dura is opened. Moderate hypocapnia, 25 to 30 millimeters of mercury after opening the dura. Relative normocapnia, normal ventilation during aneurysm clipping. Balance of the benefit of cerebral blood flow reduction with the risk of cerebral ischemia. Other modalities: head up tilt, loop diuretics, omit nitrous oxide, reduce volatile anesthetics, bolus or infusion of intravenous anesthetics. Rule out inadequate depth of anesthesia, hypoxia, hypertension, hyperthermia, venous obstruction at the neck, intracerebral hematoma. These are all causes of brain bulge during operation. Fluid and electrolyte balance. Before clipping, maintain normovolemia. After clipping, slight hypervolemia. Hypovolemia is detrimental during temporary clipping and induced hypotension. Avoid glucose containing fluids. Preferred IV fluid is normal saline. Colloid, preferred colloid is 5% albumin. Treat electrolyte abnormality, treat hyperglycemia. Tight control regimen 80 to 120 milligrams per deciliter. Control while clipping, previously they used to do controlled hypotension, but nowadays we are using temporary clips for occlusion. Purpose to reduce the risk of aneurysm rupture, to achieve bloodless field, better visualization. Controlled hypotension, systemic hypotension using hypotensive agents, risk of global ischemia, higher incidence of cerebral vasospasm, poor outcome, not commonly used nowadays. Temporary arterial occlusion by temporary clips, controlled hypertension. In temporary occlusion, there is normotension or hypertension. In controlled hypotension, there is systemic hypotension. Temporary clips cause regional ischemia, whereas controlled hypotension causes global ischemia. Temporary clips can be used for short duration, 10 to 20 minutes. Controlled hypotension can be used longer duration. Temporary clips cause dependent on collateral vessels. Controlled hypotension independent of collateral vessels. Temporary clips can cause potential vessel damage. Controlled hypotension, no vessel damage. Temporary clips possibly complete control. Controlled hypotension, lack of complete control. This is a temporary clip. Temporary clip of a feeding artery, risk of vessel damage, risk of regional ischemia dependent on collateral circulation, shorter duration, maximum 15 to 20 minutes. Methods to extend the duration of occlusion by cerebral protection. During temporary occlusion, mannitol up to 2 grams per kg, Sendai cocktail, 500 ml, 20% mannitol, vitamin E 500 milligrams, dexamethasone 50 milligrams. Up to 60 minutes of occlusion is possible. Recommended safe duration is 10 minutes, can be extended up to 20 minutes. Pentothal and intermediate, you should monitor burst suppression in EEG, hypothermia, MAP to be increased after application of the clip to improve the collateral circulation. During temporary clip application, cerebral protection can be given by mild hypothermia with passive rewarming, 30 to 35 degrees. Deep hypothermic arrest, less than 28 degrees, can be used in clipping of the giant aneurysm. Monitoring the upper limit of occlusion duration, EEG is not effective beyond burst suppression. Somatosensory evoked potential can be used in anterior and posterior circulation. Brainstem auditory evoked potential can be monitored in vertebrobasilar aneurysm clipping. Prophylaxis and therapy of cerebral vasospasm. Cerebral vasospasm is caused by the breakdown products of RBC, endothelium, lipid peroxide, cerebral microthrombosis. The cerebral vasospasm can be divided into clinical, angiographical, and symptomatic. Clinical vasospasm is delayed cerebral ischemic effect causing focal neurological deficit, motor deficit, and speech defect. Angiographic vasospasm is narrowing the lumen of the vessel. It can be graded into mild, moderate, and severe, depending upon the narrowing of the vessel. Up to 25% mild, 25 to 50% moderate, more than 50% is severe. Symptomatic vasospasm is the clinical neurological deficit correlating with the angiographic vessel defect. The pharmacological prophylaxis and therapy by calcium channel blockers, nimodipine and IV nicodipine. The dose of nimodipine is 60 milligrams every 4th hourly up to 21 days. Maximum daily dose should not be more than 360 milligrams. It can be given through rice tube. Magnesium sulfate, endothelial receptor antagonist. Symptomatic treatment of vasospasm, transluminal angioplasty, intraarterial papaverine, 300 mg. Intrathecal use of nicardipine or nimodipine. Cerebral vasospasm and anesthesia. Patient without preoperative symptoms of vasospasm, always at risk of developing vasospasm. Maintain euvolemia until clipping. Then careful volume loading. Mean arterial pressure slightly higher than baseline. Preoperative hypertension should not be treated. Post-operative hypertension should not be treated aggressively. Cerebral vasospasm and anesthesia. Preoperative symptomatic vasospasm. Volume loading under invasive monitoring. Systolic blood pressure 120 to 150 millimeters of mercury before clipping, and systolic blood pressure 160 to 200 millimeters of mercury after clipping. CVP should be maintained at 8 to 12, and pulmonary artery blood pressure 15 to 18 millimeters of mercury. Induced hypotension is contraindicated. Intra-arterial papaverine may increase ICP, may cause facial nerve palsy. Delayed surgery, low risk of vasospasm. Previously, they used it to treat vasospasm with triple H therapy, hypertension, hypervolemia, and hemodylation. Usually started in patients with an increase in transcranial Doppler velocity. How do you detect vasospasm? By close monitoring of the GCP, clinical deterioration, 2-point deterioration in the GCS. And also you should have a idea if it is anterior cerebral artery or anterior communicating artery, you should look at the palsy of the lower limbs, weakness of the lower limbs. If it is middle cerebral artery, you should look at the weakness of the upper and lower limbs. And also transcranial Doppler, now it can detect the vasospasm earlier than the clinical deterioration. Middle cerebral artery flow velocity greater than 200 centimeter or Lindy more than 6, it indicates cerebral vasospasm. The goal is to increase the cerebral blood flow and CPP and to improve the rheological characteristic of the blood. Systolic arterial pressure increased up to 120 to 150 millimeters in unclipped and 160 to 200 in clipped aneurysm.
రమణ ప్రసాద్ సార్ స్లైడ్ ట్రిపుల్ హెచ్ థెరపీ చూపిస్తుంది, అదేనా మారిపోయిందా?
అదే సార్,
ట్రిపుల్ హెచ్ థెరపీ ఇప్పుడు ఏదో మళ్ళీ లేదని అన్నారు.
Hematocrit is decreased 0.3 to 0.35. Nowadays the 2 H's are removed and only induced hypertension is followed. Euvolemia, hypertension. Invasive monitors including ABP and either CVP are essential. Prophylactic treatment initiated before aneurysm clipping is associated with significant risk of rebleeding. With early surgery, there is less likelihood of rebleeding from hypertension. Incidence of aneurysm rupture, aneurysm leak 6%, frank rupture 13%. When does it occur? During resection, 48%. During clip placement, 45%. Increases overall mortality and morbidity. Better prognosis opening of the dura. Intraoperative aneurysmal rupture and management. Small leak, application of permanent clip by surgeon. Large leak, application of proximal and distal temporary clips. Clipping is not planned and there is minor blood loss. Induce hypotension to facilitate surgical control. If blood loss, you should administer blood. Good communication between anesthesiologist and surgeon. Emergence and recovery. Extubate or not to extubate.
శేఖర్ స్పీకర్ ఆఫ్ చేయవా?
Subarachnoid hemorrhage grade 1 and 2 will have uneventful surgery, reverse and extubate. Subarachnoid hemorrhage grade 3 plan basing on preoperative ventilatory status, duration of the surgery and intraoperative course. Subarachnoid hemorrhage grade 4 and 5 keep intubated, provide ventilatory support, shift the patient to neuro ICU. Intraoperative aneurysm rupture, vertebro-basilar aneurysm, immediate extubation may not be possible. Concerns during extubation: fully awake patient, prevent stress response judicially with IV xylocard, beta blocker, vasodilators with caution. Accept modest level of hypertension, systolic blood pressure less than 180 millimeters of mercury, prevent vasospasm. Multiple aneurysm, the incidence of multiple aneurysm is 30%. Keep MAP within 20% of the baseline. Post-operative care, neurosurgery ICU, monitoring, hemodynamics, ICP, neurological status, post-operative CT angio, pain management with NSAIDs, opioids under close monitoring. Giant aneurysm greater than 2 centimeters, significant mortality and morbidity. It may present as a mass lesion. Technical difficulty, neck of the aneurysm is lacking. The ratio of the neck to dome, if it is less than 2, it is amenable for coiling. So you should always measure the ratio of neck to dome aneurysm. Wall may be traversed by perforators. 2 approaches, distal and proximal temporary clicking, dissection under the use of cardiopulmonary bypass, complete circulatory arrest, profound hypothermic circulatory arrest less than 22 degrees may be necessary. Brain protection in circulatory arrest. Pentothal sodium 30 to 40 milligrams per kg over 30 minutes, followed by 3 to 5 milligram kg bolus, then infuse 0.1 to 0.5 milligram per kg per minute. Deep hypothermia 13 to 21 degrees centigrade. Circulatory arrest up to 60 minutes. So you have to clip below 1 hour. Monitor brain temperature, evoked potentials, transcranial Doppler, TEE. So there is nowadays, some people are using flow arrest using adenosine. The time interval for clipping in adenosine is 45 seconds to 1 minute. Everything should be kept ready, and during adenosine 6 milligrams flow arrest, top-ups of 6 milligrams, and everything, pacing and cardiology should be ready. There should be no history of asthma. You can do clipping in flow arrest. The time interval there is 45 seconds to 1 minute. Complications and management: hypothermia, increased systemic vascular resistance, coagulopathy. How to reduce the risk? Dissect before inducing hypothermia. Maintain ACT between 400 to 450 seconds. Reverse with protamine. Retransfuse phlebotomist platelet-rich blood. Complications: hyperviscosity, hyperglycemia. Cerebral protection, newer modalities, ischemic preconditioning, erythropoietin, magnesium, mannitol, vitamin E, steroids, diferoxamine, sodium channel blocker, tirilazide. Anesthesia for coiling. Under general anesthesia or sedation, anesthetic consideration are the same with few exceptions. Neuroradiological suit, blood loss is less, no need for brain relaxation. Raymond and Roy, occlusion is classified into 3 grades. Grade 1 is complete obliteration. Grade 2 is residual neck is present. Grade 3 is residual aneurysm with contrast drive following coil interstices. Class 3B is residual aneurysm with contrast dye flow along aneurysm wall. The gold standard for aneurysm is digital subtraction angiography. Once the clip is the permanent clip is placed, you can confirm the placement of the permanent clip by ICG, indocyanine green angiography. You should have a micro camera in the operating microscope. You should give the dye intravasal, and after 1 minute, you can conclude the correct placement of the clip. Summary and take-home message: early intervention of subarachnoid hemorrhage is usually within 24 hours and definitely within 72 hours. If early intervention is not feasible, surgery is usually delayed for 10 to 14 days to be safely beyond the period of maximal vasospasm. Maximal vasospasm occurs in 4th to 10th post-operative. To maintain overall hemostasis, adequate cerebral perfusion pressure effectively, prevent or attenuate increase in ICP, brain swelling, and cerebral vasospasm throughout all phases of anesthesia. Of course, surgeons should be skilled to dissect and clip the aneurysm in a traumatic but speedy manner. Maximal intraoperative brain protection is required, and seizures are common with middle cerebral artery aneurysm. So you should always continue anti-epileptic measures. All these factors improve surgical success and thus ultimate overall outcome. Thank you. Sir. Hello.
చెప్పండి సార్.
Any questions?
స్టూడెంట్స్ అడిగారు సార్. క్వశ్చన్ అడిగారు మీరే ఆన్సర్ చెప్పాల్సింది.
CT scan is very sensitive in the first 72 hours. The sensitivity drops to 50% after 72 hours. So if the patient with a subarachnoid hemorrhage appears lately, you should go for MRI or CT angio.
AC and MC chances of bleeding.
Sir? Hello?
Only AC and MC chances ఎందుకు?
సరిగ్గా వినపట్టలేదు, కొంచెం లౌడర్. The CT is negative and DSA is also negative. The patient you are suspecting subarachnoid hemorrhage, you have to repeat DSA after 14 to 21 days.
మీరు చెప్పేది డిఎస్సి అంటే డిజిటల్ సబ్స్ట్రాక్షన్ యాంజియోనా?
అవును సార్.
దానివల్ల ఏమేమి తెలుస్తుంది సార్ మామూలుగా?
Where exactly the aneurysm is, and what is the main artery, and the morphology of the aneurysm, perforators, and obstruction of the ventricular outlets, hydrocephalus. And in CT also, if you suspect bleeding in the supratentorial compartment, interhemispheric bleed is there, you have to suspect anterior cerebral artery aneurysm. If their bleeding is in the sylvian fissure, you have to suspect middle cerebral artery aneurysm. If the bleeding is in the fourth ventricle, you have to suspect the aneurysm of the posterior circulation.
This is very clinical, sir, very useful. Any more questions, sir? Some chat box is there.
Sir?
Omkar asked chat box, how do I plan intubation and extubation in these cases? Because even with all precautions, there will be a rise of BP. Please comment. Because as we know, more than BP, CPP is more important, MAP is more important. Do you have any inputs, Dr. Omkar?
What are the maximum precautions you are taking, Omkar?
More than anything else, the intubation doses, drugs and all should not be given at full dose. That's more dangerous, what I understand, Srikanth and Raman Prasad.
So top-up dose of opioids or propofol and esmolol can be given at the time of intubation. And intubation should be done by a senior anesthetist.
Nothing like that, sir. If you always seniors will not be available. Only thing is, if you understand properly the simulation or the, it should not be given as per kg weight and total dose should not be given.
Titrated dose కాకుండా deep
Titrated dose మొదలు పెట్టాలి, but deep గా తీసుకోవాలి with monitoring is more crucial, because if the CPP is fluctuating more, the damage and outcome is going to be poor in the later. Omkar, anything else?
TIVA is preferred. Why inhalation anesthetics are not preferred? Because if they are used more than 1.5 Mach, they uncouple the CMRO2 and metabolism. So avoid inhalation anesthetic and nitrous oxide in poor grade aneurysms. And lumbar puncture should always be done after CT scan is normal.
Sevoflurane, sir, isoflurane కూడా అవాయిడ్ చేయాలా?
అన్నీ సార్ less than 1.5 Mach యూజ్ చేయాలి. And if there is brain bulge, you should stop and convert into TIVA.
Neuro cases always TIVA is better.
Yes, sir. Especially in grade 3, 4 and 5.
ఓంకార్ క్వశ్చన్ అడిగాడు, మర్చిపోయాడు.
హలో, గుడ్ మార్నింగ్ సార్.
సార్ ఏంటి సార్ మీరు చెప్పింది కరెక్ట్ కాదు చెప్పాలి కదా మీరు.
ఏం లేదు సార్, పిల్లలకు స్నానం చేస్తాను అవ్వట్లేదు సార్.
పర్లేదు మాట్లాడండి.
హలో సార్. నో సార్, అది మామూలుగా వాట్ వి యూజ్ లైక్ లెబిట్లాల్ ఆర్ ఎల్స్ nowadays dexmet infusion is being widely used, sir. But still there are some studies which are commenting that even though with maximum precautions of preventing all rise in ICP or MAP, still because of intubation reflex, and there was a study conducted on 35 cases where approximately 2 cases there was what you call aneurysm rupture, sir, with uncontrolled pressures, even though they were taking precautions. So I thought any new advances or any specific monitoring which we can do in our setups. only
Not
options we have.
more than that, the basic Kutumbarao.
Hello, sir.
Yeah,
Hello.
Kutumbarao. ఓంకార్
సార్ చెప్పండి సార్.
నిన్నే పిలిచేది.
చెప్పండి సార్.
ఇంకా ఇప్పుడు we have seen around 5 to 10 cases, actually not 10, 5 cases. Aneurysm cases admitted for the clipping, and the day of surgery we are going to plan for surgery today, and as it ruptured, so they gone into at least they have gone into brain also. The reason being that it's very critical, particularly for aneurysm cases. ఇప్పుడు ఏంటి sudden emotions and sudden blood pressure variations and hypovolemia. సో ఇవన్నీ కూడా సడన్ గా వచ్చినప్పుడు మనకు రప్చర్ అయిపోతాయి. సో గోల్ సిపిపి కాబట్టి మనం ఏం చేస్తాం, ఎన్బిఎం పెడతాం నేను నైట్ నుంచి నెక్స్ట్ డే మధ్యాహ్నం వరకు. దట్స్ వన్ డేంజర్, అండ్ యూ డోంట్ ప్రిపేర్ దెమ్ వెరీ వెల్ సైకలాజికల్లీ. అండ్ ద డ్రగ్స్ మనం ఉన్నాయండి అంతవరకు యాక్చువల్గా వాడు హైపర్ టెన్షన్ లో ఉంటే వాడు ఫుల్ ఫ్రీ ఆఫ్ డ్రగ్స్ అన్ని ఇచ్చేస్తాం కంట్రోల్లో పెట్టడానికి. సో దిస్ ఆర్ ఆల్ ద థింగ్స్ విచ్ హావ్ బీన్ షోన్. I have not come across to the study which has caused this reason, because if you ask any neurosurgeons, NBS Mohan is having experience and restoration and all, so you ask them, వాళ్ళ సర్జరీ 10 సంవత్సరాల నుంచి 3 సంవత్సరాల నుంచి అనిరిజం ఉంటుంది, రప్చర్ అవ్వదు, ఆ రోజు పోస్ట్ చేస్తే ఆ రోజు ముందు పొద్దున రప్చర్ అయిపోద్ది. I think I'm sure some people might have been experienced with this.
Yes sir, yes sir.
Not maintaining the euvolemia status, map, and not maintaining the calmness in the patient. These are things are important, and we are sure that we should be able to do that, and we have to go through that. And as now he is telling, మీరు అన్నారు కదా డెక్స్మెటామిడిన్ అనేది ఏదైనా ఇంటర్మీడియట్ గా టైట్రేటెడ్ డోస్ ఇవ్వడమే బెటర్. నేను చాలా వాటికి అన్యూరిజం కేసుకి వచ్చినప్పుడు మీరు మామూలుగా వన్ ఆఫ్ అవర్ ఫ్రెండ్ డాక్టర్ డేవిడ్ అనుకోండి, ఈ డజన్ లైక్ టు గివ్ రిలాక్సెంట్. ఐఎమ్ నాట్ పుట్టింగ్ హిస్ నేమ్, లైక్ పీపుల్ లైక్ దట్. So myself also, I don't like to give in relaxant immediately because I'm worried I may lose airway. That's main tension. So that time when you just put a lower laryngoscope, your CPV will go very high, MAP. The same way here, if you don't give, because the titration we are not able to do with either with the bispectral index, because at least if you are monitoring the bispectral index at the time of intubation, it's okay. And everything monitoring intraop with the ETCO2 or HFNO availability, all these things is not really possible with every one of us. So these are the reasons very important where we could able to do that. So అందుకని maintenance of the blood pressure, like intra-arterial blood pressure monitoring, is one of the important thing which I feel. Not having a fluctuation and titrating the dose for intubation is important. That's my personal feeling or experience. I leave to all the seniors. Thank you.
Sir, I want to add one point. Which patients undergo coiling and which patients undergo to clipping, and what is the mortality difference? There was one study conducted in good grade aneurysm, grade 1 and 2, at the 1 year mortality, end of 1 year, with coiling is 8.9%, and with clipping it is 10%. Poor grade aneurysms and large blood in initial CT scan, they should definitely undergo clipping. So if the patient is not having comorbid conditions like hypertension, diabetes, good grading, and aneurysm is amenable for clipping, coiling, patient should undergo coiling. At the end of 1 year, the mortality is slightly less when compared with clipping in good grade aneurysms.
Raman Prasad sir, as far as my understanding, please correct me if I am wrong. Anybody can correct me. So as far as my understanding, there are 3 things besides your clipping and coiling. One is the neck size of the aneurysm.
Yes, sir.
And the place of the aneurysm.
Yes, sir.
Third, the entire, because once it's been entered, your accessibility to the place of going there. Not only the place in the important areas. This is important. Because reachability of the neurosurgeon may be difficult in some areas, but it may be very useful for the procedure. So these are 3 things decides actually coiling or clipping, because there's no much difference between the coiling and clipping. Actually, if it comes into the Indian perspective, the cost is going to be much less in clipping than the coiling, because coiling you can do with the intervention and clipping you have to do the surgical. Am I right?
Yes, sir.
So what I understand is your surgical problem and damage and post-op, intra-op, all these things are a little bit tough in the surgical aspect. But the outcomes are much better in the clipping because you have in everything you're doing in a controlled manner. But whereas in a cath lab procedure, intervention radiologist is doing the coiling, that also we have seen because it's actually less damaging, less invasive compared to this, and it actually have given almost the same result. But depends on the skill of the person also. Most of the people, I prefer, if personally you ask me, I prefer coiling than the clipping if the money is not an issue. Because finally the results are going to be with the person who is doing it and the time and the option, because you are doing more physiological way and almost like a conscious patients, whereas you are not going to change much of MAP or CPP. That's what is my personal opinion. But in studies and that evidence, I need to see, as per you're telling, over 8.5 and 10%, 1.5% difference, and absolute risk reduction, I do not know what it is.
Good morning, sir.
Good morning.
Sir, with your permission, can I tell to Dr. NVS Mohan, sir? He's there.
Yeah, please. I think it's better
Okay.
person.
Yeah, I'm giving to him. Sir, you can speak, sir. Speak
Sir,
about.
Good morning, everybody. Dr.
morning,
Mohan
sir.
here.
Yeah.
See, aneurysm clipping is the gold standard for any aneurysmal subarachnoid hemorrhage. Once an aneurysm is clipped properly, patient will have a 100% cure. Only thing is you have to make sure that the clipping is perfect and no part of the aneurysm should be left behind. Because if any part of the aneurysm is left behind, there's a chance of recurrence of subarachnoid hemorrhage. That is one point which has to be checked by the surgeon